Good afternoon, everyone. This is Ileana Soto-Welty. I'm the Executive Director of MECA. And before we get started, I wanted to give you all an opportunity to learn a little bit more about ACEs. And I have a few quick slides to share with you. First of all, MECA is really excited to be part of the ACEs Aware program in collaboration with Early Childhood OC. The ACEs Aware initiative was launched through the Office of the California Surgeon General, Dr. Nadine Burke-Harris, and the California Department of Healthcare Services, which are leading a first-in-the-nation statewide effort to screen children and adults for adverse childhood experiences in primary care and to treat the impacts of toxic stress with trauma-informed care. The ACEs Aware initiative is built on the consensus of scientific evidence demonstrating that early detection and evidence-based intervention improve health outcomes and help mitigate the health impacts of toxic stress. You can visit acesaware.org for more information. Also, there's been a lot of grantees for the ACEs Aware grant, and Orange County also received an ACEs Network of Care grant, which is being led by Mind OC. MECA is participating in the steering committee for that and leading the Equity and Inclusion Committee. This conversation that we're going to have today on the cultural perspectives on mental health will help inform a brown paper that we are developing on the racial and ethnic implications and perspectives in the screening and treatment of adverse childhood experiences. At MECA, we've begun to incorporate ACEs information into our parent and teen mental health trainings as a way for our ethnic communities to become more aware of resilient strategies. Today's conversation is targeted to providers, but really this is something that we all need to become more aware of. So I'm going to share with you just 3 short slides on what are ACEs. ACEs are adverse childhood experiences. In this chart here, you'll see that these are the top categories: physical abuse, emotional abuse, sexual abuse, physical neglect, and emotional neglect, mental illness, domestic violence, divorce, substance use, and having an incarcerated relative. In the initial research study conducted by Kaiser and San Diego Centers for Disease Control, it was found that 2 out of 3 reported at least 1 adverse childhood experiences, and then 1 in 5 reported 3 or more ACEs. 1 in 8 reported 4 or more ACEs. So the higher prevalence of ACEs occurred for people who are low income, people of color, people involved in the justice system, and people from the LGBT community, which make them more at risk. And this slide shows the social and economic inequities that are expressed in our health and well-being make us more susceptible to disease. ACEs dramatically increases the risk of 9 out of the 10 leading causes of death in the United States, which include heart disease, cancer, chronic lower respiratory disease, stroke, Alzheimer's, diabetes, kidney disease, increase in suicide attempts, among other conditions. As the number of ACEs increases, especially those with 4 or more ACEs, so does the risk for these leading causes of death in the US and chances of experiencing negative physical and mental health outcomes. What the ACEs study has taught us is that childhood adversity is the leading cause of health and social problems in our nation and is the most powerful determinant of public health. The social determinants of health, which are the economic and social conditions that include our environmental factors, such as where we live, work, and play a big factor in exposing us to different kinds of stress. Through the network and system of care that we hope to build out here in Orange County, we want to develop buffering resources to address these social determinants of health and help reduce toxic stress. In today's conversation, we have some amazing experts joining us today, and I have the pleasure of working with them through our MECA collaborative. We have Dr. Miguel Gallardo, and Dr. Suzy Suyandong. And let me tell you a little bit more about them. Dr. Suzy Suyandong works as the Behavioral Health Director for Southland Integrated Services. Southland is a member agency of MECA. She started off her career as a clinician for Western Youth Services here in Orange County and provided treatment to students with mental illness or who were in recovery. Inspired by her own experience and the experience of her family members who had a mental illness, she became involved in this work. She was the former LA Care Health Plan Director for Behavioral Health Services. She's also a licensed clinical psychologist. Prior to joining LA Care, she worked for the Orange County Healthcare Agency for almost 20 years and worked with people with severe persistent mental illness. She served as the Orange County Behavioral Health Ethnic Services Manager and also as an outpatient mental health services chief. Suzy is well known in Orange County, and I've seen her at work in the community, and she's well respected, and I've seen her really connect with people, and she has been a longtime host of a Vietnamese radio and television program in the Vietnamese community talking about mental health, family, community, and social issues. I think she's done that since 2002. She is a constant guest speaker and lecturer at high schools, universities, and conferences on ethnic mental health and cultural competency issues. Suzy has received numerous awards. In 1998, the Asia Pacific Islander Community Service Award, the 1997 Citizenship Award from the League of United Latin Americans. In 1994, the Orange County Human Relations Award. 2010 Women Making a Difference Award. And in 2004, she was Orange County Register's one of top 30 Vietnamese Americans to watch. I've seen Suzy do some amazing work with community members through our Drawing Out Stigma program, and she has helped them create wonderful artwork and writing. So her experience is just, it could go on and on. So thank you, Suzy, for being here today. And it's my pleasure also to introduce Dr. Miguel Gallardo, who is MECA's Evaluation and Research Director. He is a professor of psychology at Pepperdine University, where he also leads the Aliento program and the Center for Latinx Communities. He is a licensed clinical psychologist and maintains an independent consultation practice at the Neurobehavioral Clinical and Counseling Center, where he conducts therapy, forensic, legal, psychological, and neuropsychological screening assessments and consults with organizations and universities on developing culturally responsive systems. He teaches courses on multicultural issues, social justice, advocacy, and professional practice issues. Dr. Gallardo's areas of scholarship and research interests include understanding the psychotherapy process when working with ethnocultural communities, particularly Latinx communities, and in understanding the processes by which individuals develop cultural awareness and humility. Dr. Gallardo is also well known in the community and has published many journal articles, books, and book chapters in the areas of multicultural psychology, Latinx psychology, ethics and evidence-based practices, cultural humility, racial colorblindness, and he is currently editor for the Cognella Academic Press on Advancing Cultural, Race, and Ethnicity book series. Dr. Gallardo discusses cultural and mental health issues on his Cultural Humility podcast, and he served a 6-year governor-appointed term for the California Board of Psychology. He is also a fellow of the American Psychological Association. And I am going to put, Miguel, your website on here in the chat so that people can go visit your Cultural Humility podcast, and you can thank me later for all the hits you're going to get. But it's such a great resource. He is always having wonderful conversations with people on current events, and so it's a great podcast to follow. So with that, we'll get started. That was a that was just an amazing, introduction to these two folks that we get to experience today. So to get us started.
They want to know how they can follow Suzy, not me.
Well, Suzy, feel free to put in the chat your Vietnamese station and radio talk show as well. So we're really honored to have you both here today. And just to get us started, both of you are amazing mental health cultural experts. If you could just share with us what informs and guides your work in working with ethnic communities, especially in providing therapy services to children, adolescents, and adults. And we can get started with you, Miguel.
Or Suzy, I'm good either way. Yeah, Suzy will start.
It takes a long time to introduce both of us, so we need to get right in. Okay. Well, it guided me. I think my personal experience, well, I was a refugee and then an immigrant, I become citizen in the US, and coming from a very war-torn country, and, you know, as a boat person crossing the sea, you know, going to another country in Asia and then get to be settled here in US. So that whole journey, and then I know that the folks that I work with, many of them were refugees, and then or that they're immigrants coming to this country, and then also coming Mali areas like Southeast Asia. There's many war-torn experiences there, and you know, and even Asian Americans in this country with Japanese American with the internment experience, all of that. I mean, that's all trauma. So with all of that in mind, when I see an individual Asian Pacific Islander, I would be, you know, approaching from learning about their historical, experience, history, where they come from, how they come here, and how they build their lives here, and everything else around it. I mean, the environment in which they come from, all of that. So that helps me to have a better picture of where the person come from.
Yeah, you know, I don't have obviously the same experiences as Suzy has, but I have, you know, being born and raised here in the United States, and you know, having my own experiences of negotiating life as a Mexican American in the U.S. And then also, I would say, you know, thinking about the historical generational trauma of that of my father and mother and my grandparents, and so all that sort of, you know, I've internalized, and that's sort of been part of my my history as well. And so even though I haven't had some of the same exact experience some of my my parents and my grandparents have, certainly had my own, but I think it's really around you know, noticing the disparities in treatment and in processes around the distribution of resources, the access to services. And I think for a long time that has obviously been a concern of mine. And so that really situates my work in many ways around trying to increase access, reduce disparities, you know, make services more relevant for communities. I think our service delivery system still makes a lot of, I think, inherent assumptions that I think, you know, indirectly and unintentionally and you know, pathologizes many folks in our communities, and that concerns me. And so I think it's around changing how we think about providing services, changing how we, you know, the healthcare delivery service systems in many ways. And so I do a lot of training of students to try to help them, you know, really think about how to do this work differently, and not really recreating the same processes over and over again. So I think for me, that drives a lot of what I do.
Great. You know, I'm wondering what you think about whether how race, ethnicity, and class play a role in impacting a person's mental health.
Mm-hmm.
Especially today, you know, with everything that we've experienced, especially in this past year, you know, racism has definitely been a key factor.
Yeah. Suzy, you want to Go.
Michael.
Oh, you want me to go? You want me to go?
Yeah.
Okay.
It's your turn.
Okay, I'll start. So I definitely, I mean, I think those aspects of those social identities of who we are, I think are just three, but there's others as well that I think are, really, Audre Lorde said there's no such thing as a single issue struggle because we don't live single issue lives. And so, we're made up of multiple, I think, social identities. I think race, ethnicity, class are certainly some of those more salient ones depending on our life experiences and whatnot. So I do think they have a and can impact. Obviously, that's going to vary from individual to individual and family to family, but I certainly believe those can be really have a direct correlation and connection to and cause and effect to someone's overall mental and physical well-being at the end of the day. We know that, I think our definitions of trauma historically, even our definition of PTSD, I think has been insufficient and somewhat narrowly conceptualized to a certain degree. That's changing a lot, but it hasn't always accounted for racism and discrimination and oppression and in people's lives and the effect and the impact that has. It's again, it's changing, and that has changed, and it needs to continue to change. But there's no question. There's been research, looking at particularly black families, African American families, and women, black women, who found themselves in intimate partner violent relationships. And when they interview these women and asking them why they didn't call the local police or the local help and whatnot, many of their responses were they were concerned about how they were going to be treated by those law enforcement services and protective services that we have in place, and the racism that they might experience as a result of that, more so than and then they'd rather endure the circumstances. So to say that race and the color of one's skin doesn't matter, I think it is misguided in many ways. And then class, I think class issues in some ways really intersect in many ways. And I think sometimes even class issues can even be more of a determinant sometimes in terms of people's outcomes, access to resources, etc. I think the concept of privilege really stumps a lot of people, because I think sometimes people, I have privilege as a Mexican American in many ways that I didn't have growing up, and more privileges now. And so I think I have some advantages because of that allow me to negotiate, navigate the world a little bit differently. But I think class certainly, there's a lot of research that's also indicated that as well. So
yeah, I would add gender to that as well. Yeah, race, class, ethnicity, and gender as well. Especially I see in the community of colors, the issue with gender, it's so prevalent in terms of domestic abuse and the issue with privilege for for the patriarchy, hierarchical component there. The issues of I think race come with race's history of that particular ethnic groups. And then the other thing is the history. In history, it says the historical trauma that is complex trauma that come with multiple and repeated traumas from individual system, and then the family, and then the system, and then the justice system that people being part of, and so that could explain more why people have post-traumatic stress disorder and have multiple triggers, or that, and then if they have grief, they have losses in their family, loss of social status when they move in here as a refugees or immigrants, loss of loved ones because of health issues and having no disparity in health access and health services. The multiple levels of trauma and become complex. So in our field, seeing people, we need to look at all of those things too. And nowadays, I think it's great to have an integrated care system with the health information that you can actually see the medications and other physical conditions that your patients do have, in addition to the mental health conditions. And I would love to see other social determinants like, housing, their employment issues, the support system, the neighborhoods where they live, all of that. It's given us a more diverse picture. And now with telehealth, you get to see patients in their homes and how they live. And then they get to show you, their belongings and all of that. And then the environment in which they live. You have a better picture than just seeing patient coming to your office and confined in that limited environment there, space there. So it's my 2 cents.
And I would say too, just to follow up, I mean, if there was ever an example of the sort of intersection of race and class issues, and it's right now during the pandemic that we're in the middle of. I mean, racial capitalism, created our system of slavery in the United States. It has created our mass incarceration system today. It's created the health disparities that we are seeing today, and what we saw in terms of the deaths and the overwhelming amount of folks, of Black, Indigenous people of color, who were being affected by this COVID-19. It's affecting the vaccine and the dissemination of the vaccine, and who's that accessible to. When you look at the number of folks who are being vaccinated at this point in time. Now, again, there's a lot of data that and variables that we have to take into consideration. But my point is that the question is not so much around, is it important? I think the question around is like, how can we develop and create more conversations and train people in these areas to really embed and integrate, the intersection of folks' social identity, whether it's gender, class, race, ethnicity, whatever it may be, into their work. And I think, if we're still asking the question, is it relevant? That's a problem. I think it's really like how do we do this better, knowing that it's certainly affecting people's lives.
Yeah, it's been a very difficult year.
Yeah.
With the pandemic, with Black Lives Matter, with Asian Americans being targeted this past year, and it's impacted, even just watching it in the news, it's impacted our mental health.
Yeah.
So, you've experienced this past year with folks, this has highlighted a lot of our disparities, COVID has. How have you addressed the social determinants of health and helping people, especially when there's like food insecurity and just stress at many levels? What are some things that you have done, some best practices? And as we roll out ACEs and we're doing these screenings on very sensitive issues, what are some things that we need to take into account? Because obviously the system can't address everything. We're not ready. We're already having disparities in terms of resources. But what have you done, and what do you think we can do better?
I think let's start with assessment first. I think one of the questions that I asked myself and I asked my staff to ask is not only to look at how people come here in this country or whether they were born here, and how their parent generations make it here in this country, and the impact of all of that in their lives, but also sometimes asking about their family, how they function in terms of if they have anger, how do they express it, what. The other thing is to ask them to define their own trauma. Because a lot of time we think, this is what we consider trauma, but for some people, trauma can be very subjective. And you ask them, what, and then you explain what trauma is, what the definition is, and looking back in your lives and what are the things that what experiences that you consider as trauma for you. And then that's when we got to learn a lot more. Sometimes we're just surprised, and then the other thing is the interaction with the system, like when you need help, where do you go and how do you get the services for this, for that. But I remember there's one story where I have a patient where, he's a young man, 16 years old at that time. And, he had depressions and he was struggling. He actually had autistic spectrum disorder, high functioning. And he had his depression since much younger, and then later were found. But then he was very suicidal, and his parents called the service, and they routed to the police department, and the police come. In fact, seven of them come to his home, thinking that, oh, he has a hammer in his hand, so he could be dangerous. So they went to his home, raided the whole house, and pointed a gun at him. And he was only 16, and he never had history of violence. He's just a kid with depression. His parent, a lot of trauma with his parent marriage, and a lot of trauma in his life, and bully and all of that. And here he was pointed the gun at him. So that was a huge trauma for him, and he's still having nightmares now of being killed by the police. Right. So we talked about the system, the service system, supposedly to provide safety, but again, it could be unintentionally traumatize the people. This young man, Vietnamese American. So now, so you want to ask about how they interface with the services that they need, the school system, or even questions like, have you been experiencing being bullied at school? The simple questions like that, it's come up, right? And then, so I think the assessment is a very important piece. A lot of time we're just looking at the present here and now and the symptom duration and frequency, but that's not, we want to see much deeper than that, and asking those questions from assessment. Maybe let me stop it here so Miguel can jump in, and then along with treatment and resource and services and best practices, I can give more input into the cultural practices that I think that could be really helpful.
First of all, I wanted to thank you for bringing up the issue of the justice system. And, I think this is an opportunity for us to look at all of these systems and see where we can make reforms. I think there's been too many stories already of, police officers responding to a mental health crisis situation. We've figured out that doesn't work. We need new models out there. So I just wanted to thank you for bringing that issue up. And I think, definitely something we need to integrate into our thinking here as we move forward. Miguel?
Yeah. I just quickly, while we're talking about law enforcement, I just want to say too, I think when we talk about it, I think sometimes people hear that we're sort of anti-law enforcement or against police departments and whatnot. And I think I just want to make sure that, folks listening know that, look, I'm not against police officers and law enforcement and whatnot. I think we just need to do a better job of sharing the resources and the wealth and taking the burden off any one particular system to try to deal with a wide range of issues that. And I think it's unjust and unfair in many ways to sort of put the burden entirely on a system that isn't prepared entirely to deal with those things. And so I think it's around re-envisioning our systems and how those work together in collaboration more than anything. And so I think when people hear like we got to defund the police or whatever, and people start to panic and everything, it's like it's not about getting rid of. It's just a matter of sort of how can we do this better moving forward in some way. So I just want to maybe just say that in general, because I talk a lot about it too, and I think sometimes people misinterpret my sentiments around it. But what I would say, just think about what Suzy just mentioned around in your question, Leanna. I think if we make the assumption, and I make this assumption, that everything people bring to us and wherever that is, whether it's in an office, in their home, in the agency, is socially produced, socially derived, socially developed in some ways. We cannot look at what they're experiencing and what they're dealing with without looking at the multiple contexts in which their lives are embedded and created. And so what that means is that, for me, it's around how do I take that into consideration and really think about, when I think about intervening or think about, assessing, it's like, how am I assessing for the multiple contexts and circumstances that people's lives exist in trying to understand how to best engage in those multiple systems in whatever way I can, as a mental health provider. And so I never, if I place the burden entirely on an individual or a couple or a family or a child for whatever they're dealing with, in some ways I think that reinforces our societal mental health status quo. And that is that everything, that the individual bears the full burden of responsibility for everything that they're experiencing. And again, I don't know that, I don't want to make the generalization that everybody sees it that way or everybody does it that way, but in general there's this sort of, I think, underlying assumption that that the individual is the sort of sole bearer of responsibility. And it's not that I don't want people to think that they have control and that they can do things differently, but in some ways, I work from a liberation psychology perspective. It's like, how can I help someone understand that maybe how they see themselves, how they understand what they're experiencing, is embedded in larger social context, so that the burden is not just entirely placed, they feel flawed. They
Right.
feel like they're the problem in some ways. Yeah, Suzy, go ahead.
Thanks so much, Miguel, for bringing this up, because there's a lot of issues of shame and guilt.
Right.
And shame, what is shame? The definition of shame is something wrong with me. But a lot of time working with my patients is that there's nothing wrong with you. There are things that out there, the system, the family, the service system, and the messages that you've been receiving about yourself and the abuse that you're getting, that change your internal dialogues and how you see yourself, you see the world, how you see others. And then you yourself, in Buddhist psychology is like a lotus, but then we have so much mud cover over that, and we just need to clear those mud out so we can see the lotus and the strength and the potential from within. So got to see that in that sense. And I love the social work perspective. Like, the person is in the environment. We need to assess the environment with multiple layers, and not, like Miguel said, the burden is not just not bearing on that individual. So that's what help the clients to feel, I'm not blamed for it. Then I have potential, I have resource, I think, to overcome, instead of feeling that's something wrong with them.
Yeah.
Yeah.
I think Suzy, what you're saying too, and what I think about is, like, I think a lot of times people have found the most advantageous and healthy way to deal with unhealthy situations and circumstances, right? It's like, and I don't think I think we have to change our sort of lens a little bit in some of this. We were talking about this earlier, and we said, I always tell it, like, look, if you're doing an ACEs screening, whatever it is that you're trying to understand people's histories and the social production of what they're speaking, find out what's right with them first. Like, we need to find out what's good about what's right with people at the starting point, right? Yeah.
I think assess their resiliency.
Yeah.
The ability to navigate, overcome, adapt, all that. And with ACEs, we need to have the resiliency assessment that could, identifying strengths and resources and things that have worked, that the individual and their families have used and it worked well for them.
Right.
I think that will help us to not pathologize our experience so much, but also that knowing that people have the strength to make meanings and make differences and making the best out of their experience and utilizing that. I think so that, neutralize and not to pathologize everything and stigmatize with folks who have been, experienced so much trauma in their life. And yeah.
Miguel, thank you for bringing up the idea that we tend to blame the individual. And I think that's one other thing that we need to reimagine and look at this work through an anti-racism frame. Mm-hmm. Because, as we roll out the system of care here in Orange County, one of the things that I hope we do is we put equity, inclusion, and diversity and anti-racism at the center. Yeah. Because we can't just blame the individual. We also have to look at the environment and the system and the structural racism and the history that we've experienced. One of the buffering resources is getting out in nature. But if you're living in a crowded condition where you don't have access to walk around and be safe in your neighborhood or a park nearby. That's not a resource that's necessarily available to you.
Mm-mm.
And so I know for me, nature has been one of those things that I have gone to during this pandemic as a way to, address my stress. But, we have to understand that not everybody has access to those resources,
Mm-hmm.
that are readily available, living in a nice tree-lined street or what have you. So there's just a lot of things I think that we need to consider as we do these ACEs screenings, the strengths of the individual, but also like what are the resources that we still need to address. Suzy, is Suzy
You
Houston?
lose her? Maybe it was something I said.
He'll be back. But I really wanted to see what best practices that you might have, Miguel, in terms of doing the screening of ACEs,
Yeah.
how we can do that in a better way.
Yeah. I know Suzy wanted to address this as well. So when she comes back on, hopefully she'll talk a little bit more about this as well.
Problem. She'll be back. Yeah.
Yeah. I would say that I think how and when to do the screening is, I think, of critical importance. And there's a lot of, I think, debate and dialogue around how to do it, when to do it, etc. I think from my perspective as someone who's in the mental health professions and disciplines and fields, it's around, I think, some of the questions are very I think they're all important questions to get at in some way or another, but I think they require some level of trust between the provider and the patient, the client, in really responding to those. So I think how we go about engaging in that process is really important. And then I think the other so when to do it and how to do it matter. I think that affects the information that we may get back in some ways. The thing I always try to tell folks is like, look, how do you think folks are, how I want to know like how I'm being perceived by the people I'm serving, because that's going to make a big difference in terms of maybe what information they tell me, maybe what they don't tell me, whatever it may be in some ways. And so I think knowing that ahead of time allows me to think about how I might engage in a conversation around some of these important areas. But I think also thinking about the questions that are being asked, for example, on the screening, those can look differently and be defined differently for people in different ways. And so I think how we may ask questions of those direct questions of people, but they may not conceptualize it or understand it in that way for themselves. And so the answer we get back or their response back may not be necessarily entirely reflective of maybe some of their experiences. If they don't feel trusting of what's going to happen with the information or what we're going to do with it, they may not want to disclose. Suzy mentioned shame and guilt earlier, and I think that comes up for folks a lot of times. I think also it's important to know that in some ways it doesn't account for some of those social historical experiences that many communities of color may have. So like, fleeing from countries of origin, war-torn countries of origin, being displaced, community violence, homelessness, whatever it may be. And so I think when we think about trying to implement and ask, certain questions like this, it's around understanding also the person's context and historical context to know that, when I talk to a lot of folks in the communities who have experienced high levels of trauma, and Suzy mentioned complex trauma, so the sort of multiple experiences of trauma over one's lifetime, when they think about some of the things that are happening now, they may not see those as traumatic or as problematic. It's not because it's okay or whatever, but it's just their own conceptual framework and understanding is embedded in their histories and in their cultural context, etc. None of abuse in any cultural context is not accepted and shouldn't be accepted in many ways. But I think parent and child rearing practices do vary. And I think we have to keep that into consideration. It looks differently. And how we understand it as cultural beings also makes a difference in terms of how we maybe respond to questions. And so I think we have to consider I think all those other variables that I think the screening doesn't maybe necessarily capture. And then I think the other thing too is that in some ways it's sort of attributing equally these different experiences to each other, if that makes sense, in terms of the weight given to each of the questions, and I think that also is going to look differently, because some of those experiences are not going to impact people in the same way as others are. So I think that it's not that we shouldn't do it. I think it has to be one part of a more comprehensive assessment, and it's a screener to help us do further assessments and evaluations of something more holistic and comprehensive, if that makes sense.
Right.
Yeah.
And Suzy, the question that I asked was, what are some best practices for doing the screening, and also some trauma-informed approaches? I know that this is, one of the areas of expertise for you. So if you could share a little bit.
So again, with assessment, we need to look at, like Miguel said, the pre-migration history and post-migration experiences. We need to look at the trauma for refugees or immigrant families. We need to look at the child rearing practices, not to make conclusions of anything, but just to see how the individuals see that as well. And then acculturative adjustment stress, availability of their social support system. There are people who have so much support system when they were back in their homeland, but when they come here, it's very different. And their family can be, distant from all over the states, instead of being in one unit like it used to be in their own home country. So, and the other thing is how the understanding of the family, the service system that this family, this individual interface, and the policy that impact them. So these are things that we need to look at. As far as the treatment best practices, and I also wanted to touch base on looking at some of the how they look at authority, the respect for authority, how they look at the family hierarchy, how they look at the gender socialization within their family and their community. People like Asian Americans, women being divorced is very different. We looked at differently, especially for some other older cultures for being divorced. They're very different. And then domestic abuse and the severity of the domestic abuse also very different from in Asian families, and the level of acceptance of that by the in-laws or by the relatives of domestic abuse, is also different too. And then differential of acculturation, the rate between the children and the parents. And then the issues, again, it's the child rearing practices, and also the values related to suffering. Like Miguel says, some people, they learn to have higher tolerance for abuse, perhaps, or trauma, and also their religious faith in terms of fatalism, or more acceptance, and whether that can be a strength in itself, and at the same time how that can be can help them to reach their wellness and live a healthier lifestyle. So we need to kind of go in between that and help them navigate and design their own the things that make sense for them, giving the where they come from and what they can learn now to make the best of it, and not to look at duality either or, but how to integrate that. So for that piece, and then again for the culturally sensitive trauma treatment, we look in that when we do therapy with kids, with definitely family therapy, child parent psychotherapy, not just the kid. There's some families have the idea that, okay, I dropped my kids there, my kids have problem, I played no part of it, right? Or just blame all on the kids. But in fact, when the parents have mental health condition, when a parent have trauma in their lives, their child rearing practices or how they parent their kids, a lot of it out of fear, a lot of it out of out of fear, hypervigilant response to anything that they don't feel comfortable or things that they unknown to them. We need to bring it to the surface for the parents. The other thing is trauma-focused cognitive behavioral therapy, integrated treatment of complex trauma. I find mindfulness practices is wonderful to help calm the, increase a sense of safety and calm the very overwhelmed emotions that often folks that have trauma have to go through and been so conditioned to respond to their environment out of survival. So the mindfulness is absolutely helpful. The other is EMDR, eye movement desensitization reprocessing, vary to work on traumatic memories, and also self-compassion skills, self-compassion practices. Because with trauma, a lot of us, we learn to not connect to ourselves, not being able to connect to ourselves, and not relying on ourselves because everything is just, so much is out there, and we forget about taking care of ourselves and rely on our own resources, our own inner resources, and the relationship with ourselves. So self-compassion practice is also very helpful, in addition to mindfulness practices. So these are the things that I see in the treatment, but I would love to see in the community having more yoga practices, more Tai Chi, more martial art, more any body movements that are culturally based, that helpful for the community, and if they can get access to it, even dance, with their own cultural music, and if these are available in the community and it's free for them to be part of, or just by donation or whatever, more people participating in body movement, because trauma accumulated. There's a book called, The Body Keeps Score. Mm-hmm. Trauma accumulated in our bodies, in our physical body, and so we have so much. With ACs, we have so many physical conditions that come with it. And with body movements and exercise and Tai Chi, mindfulness, brain-based experiences that enhance their functioning, why not, and make it more social and community-based. I think that would be so helpful. We can do that, and a more support group where people can connect, tell their stories, and making sense of their story, reframing their stories with arts, with storytelling, with any kind of expressions that they are free to make sense of it. I think these are the processes I would love to see, but I as you all know, we're not there. There was so much, not being invested to help our community to be a healthier communities.
Yes, thank you, Suzy. Those are all great ideas, and I think we need more of those resources.
And even field trips, for folks to go to nature. And nature, body movement, eat, sleep, love, purpose, and all those things that help people be well. So why not, focusing on wellness and creating that mediums for folks to be part of.
Yes. For me, nature is definitely really healing. I wanted to ask both of you, in dealing with all of these adversities, as a provider, if someone doesn't have these experiences that they can relate to, and helping to screen and treat someone, and if they don't have the experiences to relate to the client, what are some things that we should be doing? What kinds of trainings can they take? Because these are definitely, we don't have enough diverse workforce, I think, sometimes, and so it can create a discrepancy or a lack of connection. So what can we do to bridge that gap for folks?
Mila, you want to go first?
Okay. So I think it's a good question. I think it what I would say is that it's impossible. I think we're not going to always have the same experiences that those that we're serving are going to have. I think when we do, that can certainly be helpful in some ways. We also have to be careful that we don't, over-identify and then, lose our role as in our roles to sort of, help others in some ways. But I think in general, it certainly can be, I think, understanding, and having walked in somebody's shoes, based on their experiences is, I think, can be a very advantageous and important part of the therapeutic process. I'd say that for many, many folks, they're not going to always have those experiences. And so what I always try to tell people is that think about the emotional experiences people are having. Because I think when we think about the emotional experiences people are having, it is likely that we ourselves have had, we've been through that range of emotional experiences, whether it was sadness, whether it was loss, whether it was stress, anxiety, whatever it may be. I think understanding what are the emotions connected to the experience. And I think sometimes it's there where maybe we make connection around the feelings and the emotions that one is experiencing based on their experiences that maybe we haven't had, but maybe we've had our own experiences that have cultivated, or we have felt in a similar way, even if it was an entirely different experience or situation. And so I think it's around, as human beings, we experience a range of emotions. That's all of us. And so I think even when we talk about trying to destigmatize, it's like, one of the things I always say is that, look, if you've ever felt some of these emotions, you're having a very human experience. And I think that goes for all of us on some level, in some way or another. The whole pandemic, for those who said they weren't feeling a thing before, they're feeling something now. And for those, so I think the positive of this whole situation, this whole last year, has been, I think, our discussions and centering the well-being of one's emotional health and well-being has, I think, risen a little bit in status and in importance. And I think that's important. But I think connecting on the emotional level is, I think, one way to go about doing it. And then I think it's important for us to educate ourselves about what those experiences might be, knowing that book knowledge and training knowledge is never going to override one's personal experiences with those, whatever it may be, because it's going to look differently. But I think it gives us a framework and a foundation that we can begin to understand and maybe begin to navigate some of those experiences with that we haven't had.
Great, thank you, Miguel.
Mm-hmm. I would say, even people who have the experience, it doesn't guarantee that they can do a better job. Sometimes they're not able to take care of themselves. It may be they may be their own, liability with the clients too, So I think the issue here is, how open are we? How curious are we? How motivated are we to learn? Open, curious, and learning attitude would go. And the other thing is empathy. The empathy skills would help you open up with that compassion. That would make a difference. I do think, and also I think for all of us, I mean, in this helping field, our own well-being is the tool. Our own personality is the tool. Our wellness is the tool. Our own self-compassion is the tool. So and like Miguel said, that could be as universal as human emotions. Yeah.
Great, thank you. So one last question. As we develop our brown paper that we'll be submitting for this ACEs Aware grant that we got, as well as we launch this network of care for Orange County, what recommendations do you have so that we can develop a system that is culturally responsive for our communities?
I definitely suggest that we have resource navigators, alongside. We used to call them as case manager, but I think the resource navigator is much wider definition to help folks to connect to resources within their community, not just for social benefits, not just for government benefits, but also community resources for their wellness. It could be from support group to a yoga, tai chi, meditation classes, a temple or churches that have activities for these folks. So definitely a resource navigator supporting, yeah.
Great.
And then also, like I said, all the classes, community classes, we're focusing on field trip for nature, body movements, art, and yeah, and support groups and even dance. Yeah.
And same question for you, Miguel, but if you could talk a little bit about how we can do this also and addressing the stigma around many of these issues. I know you help Emeka a lot with our stigma program for the past 10 years. And so you're sort of a stigma expert. So
well, I don't know if I'm a stigma expert, but but you know, I guess I would say that part of what helps, I think we have to do a better job of training and preparing folks to do the work. I think, you know, a lot of times it's like these initiatives, these guidelines, these screeners, whatever it is that, you know, there's a funding source. It's like, here's money for this. Here's this we want you to do. And then I think it stops there most of the time. And I think, you know, we're asking people to do something that I think certainly are important things, but I don't know that we're preparing systems and individuals in those systems to be able to implement these, whatever it may be, in a way that I think is more congruent and consistent with some of the communities that we're trying to work with and we're trying to help and serve in some way or another. And so I think that also helps with trying to reduce, you know, the stigma that I think a lot of folks, because I think a lot of folks there's a lot of shame around, you know, talking about these issues and seeking help for sort of mental health conditions. And, you know, if there's been any kind of trauma in the family that's around intimate partner violence or anything like that, I mean, you know, it's like you know, I think the expectations that people, our systems are set up to where it's like, we expect people to come to some place they've never been to talk to someone they've never met before and never had any contact with them before maybe, and to just disclose their personal history in life. Does that sound appealing to you or welcoming? No, it doesn't. And so I think even that, we have to rethink, I think, a little bit about, you know, how we implement and how we train our staff, faculty, community members, staff members, leadership, administration, whoever it may be, in doing these things. And I think we also have to be creative in how we do our work. I think the more structured we try to make things, the less creative people can be. And so I think there needs to be some room for creativity, cultural creativity, to allow people to develop and implement a lot of the things that Suzy was mentioning in a way that's going to be, you know, consistent with those communities, still get funded, and make them more accessible in many ways. So, yeah.
great. Thank you. Thank you so much to both of you for being part of this Lunch and Learn conversation. I did put a lot of links for more information in the chat room. And Suzy, if you have a chance to put information about your any other work that you do or resources for yourself, if you have a website, or people were asking about the show that you do. I know it's probably in Vietnamese, so I know we weren't able to answer everybody's questions today, but we do have future conversations taking place. And I will put the links in here. Both Miguel and I will be part of those conversations, along with some other key individuals in Orange County that are experts in ethnic communities. And so we welcome you to sign up for those. I think the next one is on parenting practices and ACEs. And we also have a trauma-informed webinar, I think, in June as well. So those links are in the chat room. I just want to thank everybody for being part of this. And, you know, we look forward to some exciting work that's going to take place in the future.
Thank you, Suzy.
Thank you, Ileana. Thank you.
Yeah, thank you both. Yeah.
Take care, all.
Okay.
Bye-bye.
Bye.